Hello, my name is Tom Evans, and it's my pleasure to welcome you today to this presentation on the shift from volume to value. The intent of this discussion is, in case anybody hasn't noticed, we've had a gut-wrenching transformation about to occur with regard to physician reimbursement, and it comes in the form of the macro legislation. The intent of this presentation today is to kind of walk us through what that means. It's pretty obvious that Medicare and Medicaid, frankly the federal government, have decided to move from a volume-based to a value-based methodology for payment for health care. And as you can see here, this is from the New England Journal of Medicine, the highlights here, setting the value-based payment goals. HHS is firmly committed to moving to a different reimbursement system, and the strategies are basically to drive progress. There are incentives in place that will be working to reward high-quality health care. We're looking to improve the way care is actually delivered and find sustainability in how we deliver that health care. And then the idea also is to accelerate the transformation, to move this process quickly. I think everyone knows that our country is challenged right now financially. So to do it, to make it sustainable, and to do it quickly. This slide just depicts the federal government's commitment to moving to that value-based reimbursement system. We've been in the traditional fee-for-service system, and you can see on this in 2016 and 2018 the federal government's commitment to try to move to a value-based system. The periwinkle blue in 16 shows that 85% of our payments in the fee-for-service piece are anticipated to be tied to quality. We hope by 2018 that that'll be at 90%. More importantly, in the navy blue area, in 2016, 30% of those payments will be in some alternative payment methodology, whether it's an ACO or some kind of a risk-bearing situation. And the vision of CMS is that this will be 50% by 2018. What's important for you to know is that this is 2016 and 2018, but in 2019, this new program called the MACRA kicks in. What is the MACRA? Well, I think, first of all, I have to preface that with what is the sustainable growth rate. Remember that for the last, since the 90s, the later 90s, we have been in the physician community, in the outpatient arena, dealing with this sustainable growth rate methodology, which what the federal government was doing was in an attempt to reduce how much we paid each year. They just kind of put a cap on it and began to reduce it every couple of years by 2%. Well, we never really had the courage as a country to make that go forward, so what happened is we would not do it but kick the can down the road for another 2-year period. So it just ended up going from 2% to a 4% penalty to a 6% penalty, and by the time this bill was finally repealed, it was almost maybe over 30%. The sustainable growth rate has been a bane to the provider community, the clinician community for years, and basically the good news is it's been repealed. The other news is that they had to repeal it with something that would actually be effective at reducing healthcare costs. So the MACRA was introduced. What is the MACRA? By the way, first of all, the MACRA passed the Congress, the United States Congress, by some of the highest margins in both the House and the Senate. And this is not tied to the Affordable Care Act. This is a separate piece of legislation. And because it's one of the most bipartisan pieces of legislation passed in the last 20 years, it's a clear message to the provider community that Congress is firmly committed to value-based reimbursement going forward. It doesn't matter what happens to the Affordable Care Act. This piece of legislation is here to stay. Congress has said we're going to value-based reimbursement. So what does that mean? According to this slide, again, the MACRA is the Medicare Access and CHIP Reauthorization Act of 2015. President Obama signed into legislation in April. It permanently repeals the sustainable growth rate legislation, which has been driving us nuts for 20 years, but it does change the physician payment schedules going forward. And for the MACRA will apply to all physicians in the country with regard to Medicare. All physicians will have to go into one of two tracks, either the merit-based incentive payment system track or an alternative payment model. And I'm going to talk about both of those in a little bit of detail. First of all, with regard to the merit-based incentive payment system, or MIPS, this program, as I mentioned earlier, this will kick in 2019. It begins January 1st, 2019. That means reimbursement is altered on January 1st, 2019. And one of the messages about that is they're going to have to base that on something, so that will be 2017 and 18 performance. What's included? How will this be determined? Well, it includes, this payment methodology will include things that they've been trying to get us to do for the last 8 or 9 years. The meaningful use components of the electronic health records, the physician quality reporting system, which has gone from being an incentive to an expectation to now a penalty if you're not doing it, and then additional volume modifiers and some other components. That will be woven into this. What will happen under MIPS is all physicians will be scored. They will take these different components that are currently expectations and some other measures such as utilization measures, and it'll kind of be smushed together, and physicians will be given a grade between 0 and 100. All physicians in the country in the MIPS program will be graded in this big pool. So if you get a 47, you'll be compared against the whole rest of the country, or a 67. One place you'll be good, above the average, the other one you'll be less than. That score will be used to determine an adjustment to your current Medicare payment going forward. So there is a high incentive. This now incents us to do performance improvement, so that it's going to be our volume times some kind of a performance measure going forward. The adjustment to what you're currently being paid can be positive or can be negative. So it's an important realization that now we're all clinicians will be in competition to kind of continue to raise the bar of care across the country. This gives you an idea of how that score will be determined. There are existing programs, as I'd mentioned, that will be merged in, so meaningful use and PQRS, but there will be some other measures on utilization and other things that have yet to be determined that will be mushed together to form this composite score that will be applied to us. And as I'd mentioned, this will have real value because this factor, whatever the factor is based on your score, will be multiplied by your volume to determine your reimbursement. So this factor could result in your income going up or going down. Interestingly, the impact of this changes over time. So in 2019, remember in 2018, that'll be your last year of meaningful use in PQRS, but in 2019, it will be the first year of the penalty or reward. And I'm just going to talk about the penalties here. But in 2019, the maximum penalty that you can get based on your performance is 4%, but it goes up from there. In 2020, it's 5%. In 2021, 7%. In 2022 and beyond, you can have up to 9% impacted, a 9% decrease in your funding based on your score. So the other model here is the advanced payment model, and the APMs. This is basically, are you participating in a larger group where you're taking risk, like an ACO, or participating in a Medicare Shared Savings Program. The definition of an advanced payment methodology, it could be a program that you're participating, again, like Medicare Shared Savings or a Pioneer ACO. But it also, there could be other CMS demonstration projects. One of those would count, and if you're in that, you do not have to go into MIPS. It is important to note, however, that just any old ACO doesn't count. It has to be an approved, it says on this slide, a defined APM. It has to be an approved methodology by CMS. Their job is to bend the cost curve. So just if an ACO is not bending the cost curve, it may not be one that is approved by CMS. Again, there will be established thresholds, but this methodology, I think many folks are getting into ACO types of models, but again, you're going to have to be in one or the other. So, where does this Transforming Clinical Practice initiative fit in? This slide very clearly kind of describes it. Remember that TCPI is a national project. It has 29 practice transformation networks, and the goal is to provide hands-on support to those physicians who are going to be eligible for the MIPS payment methodology. The idea, there are 850,000 clinicians in the country. The idea is to work with a subgroup of about 140,000 of them in a big learning community. And these 29 PTNs will be finding best practices, working to eliminate barriers, and equip their members to get their very best scores as they go forward with this. We are living in a new world, and I think it's very important for us to realize that 2019 is coming. We have to embed practice transformation techniques into how we deliver care. And the idea of this program is to equip providers to be able to succeed in that new world. So with that, I'll just close that this is our website, and we are operating as Compass PTN, so we are there to help you, and we look forward to hearing from you as we move forward into the future. Thank you.